information's on the page, so welcome.
Perfect. Thank you for joining tonight. Jen, if you don't mind to do a short introduction.
Yeah. Hi, everyone. My name is Jen. I live in Raleigh, North Carolina. I'm BRCA1 positive. I had my prophylactic mastectomy in July, and I'm in the middle of planning either an oophorectomy or hysterectomy for later this year. So this is a very timely topic for me, and I'm happy to be here.
Okay, thank you for joining. I appreciate your support. Toby?
Hi. I'm not BRCA1 and I'm not BRCA2. What I'm here for is to listen to all of these stories, really understand, and I listen to every one of Dr. Diaz's calls, as well as Dr. Kalfer and a lot of other people that come on, so that if the girls, for some reason on the board or somebody you reach out to is busy, although I'm not in your shoes, I can understand what it's about. So that's me, and I'm always here and make myself available 24/7.
Thank you. Lorraine?
Sorry, my name is Lorraine. I'm actually in New York City, and I started getting a hot flash right now. I was diagnosed with uterine cancer, but I do have the CHEK2 gene for breast cancer and a lot of breast cancer in my family. So
Thank you for joining.
Thank you.
Kamali?
Hi, I am BRCA2. I recently completed treatment for stage 3C ovarian cancer and getting my body stronger and ready for prophylactic mastectomy in 2021. And I'm happy to be here as always. Thank you.
Thank you. Jessica?
Hi, I'm Jess, BRCA1 positive. I just had a prophylactic bilateral mastectomy. It will be 3 weeks ago on Friday. And like Jen, I'm in the stages of planning an oophorectomy or hysterectomy in the next year or so. So I'm new to the group. I just joined actually the Instagram group this week, and this is how I found out about this wonderful call. So thank you so much. I'm happy to be here.
Perfect. Thank you for joining and sharing your story. Beatrice? Lourdes? Lourdes, can you hear me? Catherine?
Hi, my name is Catherine Wenmark. I live in Key West, Florida. I'm BRCA2 positive. I had a prophylactic double mastectomy about 4 years ago. So I'm just happy to be here and learn from you guys.
Perfect. Thanks so much for joining. Carmen? Carmen, can you hear me? Oh. Tammy? Can everybody hear me okay? Just out of curiosity. Okay.
Yeah, we can hear you.
So if those of you have not gone and want to go ahead and welcome yourself, I've called a couple names out and didn't get responses, you can unmute yourself and give a short introduction. Melissa, you can do your introduction later on. You have the kids in the car. We'll catch up with you in a little bit, no problem. Some of us are moms, obviously, and dealing mom life and coming on to make sure that we get the education. So I appreciate that support from you guys. What I'll do is I'll just start moving forward with the call. In just about a minute or two, we'll get started. Yvette, welcome. Thank you for joining. So good evening, welcome. Thank you everybody for joining the call tonight. We have a guest speaker, Dr. John Diaz, a gyno-oncologist. Thank you so much, Dr. Diaz, for joining. I am Tracy Milgram-Posner, the founder of BRCA Strong, where we empower, support, advocate, and educate survivors and thrivers to eliminate the feeling of isolation and help you feel whole again. We do that by funding post-mastectomy garments and lymphedema sleeves, as well as post-mastectomy pillows to women who need them throughout their journey. So if you or a family member need our support, feel free to reach out to myself at any time or any one of our board members, because we'd love to support you. Tonight being September Ovarian Cancer Awareness, you know, many of us hear about the diagnosis later on or aren't educated about it. So we brought on Dr. John Diaz, an expert, to touch base on this. So again, thank you so much for coming on and donating your time. We appreciate your support.
Thanks, Tracy. Appreciate it. Thank you, everyone, for having me and for making the time to come together, especially September, which used to be Ovarian Cancer Awareness Month. Now it's Gynecologic Cancer Awareness Month. And it's really important that we have these sessions to kind of educate ourselves. So I usually wear in the operating room either a Miami Hurricanes football scrub cap, because I love Hurricanes football, or I'll wear a Superman scrub cap because one of my patients gave it to me. But this month I've been wearing a teal scrub cap, and everyone's been asking me, why'd you change scrub caps, John? What's going on? And these are people in medicine, many of them women, and I have to remind them that it's teal for Ovarian Cancer Awareness Month, and most of them aren't even aware. And these are people that work in our hospital, our nurses, and educated. So we really need to spread the word about GYN cancer awareness and ovarian cancer awareness. So Tracy invited me, and I gladly took the opportunity to speak with you guys. We're going to talk specifically about ovarian cancer tonight. And this is really a talk for you. So if you have questions, interrupt. Otherwise, we'll get through it at probably about 15, 20-minute talk. And then I find I've done a couple of these with Tracy, and there's always a lot of great discussion afterwards. So we can either have questions during the presentation, or we can talk afterwards, and I'll stay as long as you guys want. So with that, Tracy, can I share my screen?
Yes. Okay, perfect. It's ready.
Okay. All right. And can you guys see my screen okay? Great. So today we're going to do ovarian cancer 101. And the idea, again, comes from, I feel that although we talk about ovarian cancer, a lot of people don't really understand some of the basics about this. And so that's kind of the idea for today. So this is where I work. I work at the Miami Cancer Institute. It's down in South Florida. It's part of the Baptist Health System. And we're actually the largest cancer center in the state of Florida. We're 500,000 square feet. 100,000 square feet of this is devoted to clinical trial research, which is something I lead for the Gyno-oncology group and actually for the entire cancer center. And we're also affiliated with Memorial Sloan Kettering. This is where I did my fellowship, as Memorial Sloan Kettering is one of the top cancer care centers in the world. And one of the benefits of our alliance with them is we can bring now a lot of the expertise and the clinical trials from New York down to South Florida. Many times when people get sick in South Florida, if they have means, they leave South Florida. They go to New York, they go to Boston, they go to Houston. But for most people, that's not an option. So it's really important to me to be able to bring that down to South Florida so every woman and men, but I mostly take care of women, have the opportunity to get the best care down here. So we're going to start with some basic anatomy. This is your uterus, okay? These white things here are the ovaries, and these tubes here are the fallopian tubes, which connect from the ovaries to the uterus. This is a side view. So again, this is your uterus here, okay? This is your cervix, this is the vagina. You can see right in front is your bladder, okay? And this is the urethra, right? And behind is the rectum. So it's not uncommon when women have issues with their reproductive organs that they may feel other symptoms. So if you have a big fibroid growing here in the anterior part of your uterus, it will push on your bladder. It's not uncommon when you come to see me, and they say, you know, I have to go to the bathroom really frequently, and we'll do an ultrasound, and we'll find a huge fibroid pushing on that bladder. Or there are times when you'll have rectal symptoms. It's not uncommon with ovarian cancer to this space between the back uterus and the rectum to be implanted with tumor. And a lot of times patients will have rectal symptoms. So you'll have symptoms that sometimes maybe you'll attribute to other parts of your anatomy, but just remember this relationship between your GYN organs and your bladder and the rectum. And this is the same thing, but an MRI. So here again, you can see this is your uterus. This white line is the endometrial lining, okay? This is what forms every month when you menstruate. The endometrium is what you bleed. This is where the baby's implant, and this is where you could develop potentially endometrial cancer. This little white area you see here is a submucosal myoma. And again, you see that relationship. Here's the rectum back here, here's your coccyx, and here's the bladder. So this is looking down. This is kind of the view we have when we operate. Again, here is the uterus, here's your bladder up front, here are your tubes and ovaries, and here's your rectum behind. And this is what it looks like in the operating room. It does not come labeled, unfortunately. But again, here's the uterus, ovaries, and fallopian tubes. And this is important. This is important for when we talk to women, especially in my office. I'm sometimes surprised at how little women know of their own anatomy. And certainly some of the nomenclature that gets used to describe surgeries doesn't necessarily describe what's actually being done. So when we say a hysterectomy, what we're talking about as physicians is we're talking about removing the uterus and the cervix, okay? And that's what you can see here in this orange line. This is what's called a total hysterectomy. Oftentimes when lay people speak about a total hysterectomy, what they're talking about is removing the ovaries. And again, for us, a total hysterectomy means the uterus and the cervix. Again, it has nothing to do with the ovaries. A partial hysterectomy for us means removing just the uterus and leaving the cervix behind, which really there's no indication to do the surgery. And again, this has nothing to do with the ovaries. A lot of times when women say, oh, I had a partial hysterectomy, what they mean is they had a total hysterectomy, but their ovaries were left behind. So these are some of the differences when what lay people talk about, when we talk about. When you remove your fallopian tubes, that's called a salpingectomy, okay? And the most common reason for doing that is for birth control measures. Women will have a C-section. At the time of C-section, they'll have their quote-unquote tubes tied or they'll remove it. But in the world of ovarian cancer prevention, there's a lot of evidence that much of the ovarian cancer actually starts in these embryo, these ends of the fallopian tubes. And by removing your fallopian tubes, you actually decrease your risk of developing ovarian cancer, really fallopian tube cancer in the future. And in women who carry a BRCA mutation and are increased risk of developing ovarian cancer, and maybe they've completed their childbearing, but maybe they're young and they're still not ready to remove their ovaries, one of the things that we can sometimes do is remove the fallopian tubes while we get to a point where they're comfortable removing the ovaries at some point in the future. And then oophorectomy, that's removal of the ovaries, okay? So if you have what we call Miami, a sacramento total, it's a total hysterectomy, bilateral salpingo oophorectomy. So that's removing the uterus, the cervix, both tubes and ovaries, okay? So I want to talk a little bit about ovarian cancer. And there are essentially two types of ovarian cancer. There's epithelial and there's non-epithelial. Epithelial ovarian cancer are those ovarian cancers that start in the epithelial lining, which is the outside lining of the ovaries. Non-epithelial are those that start in some of the other cells, like the germ cells or the stromal cells. And these are kind of the two major categories of ovarian cancer. Within epithelial, we have serous and mucosa. But usually when we talk about ovarian cancer, when we talk about it either when it comes to BRCA or when we talk about ovarian cancer statistics, we're generally talking about serous epithelial ovarian cancer. The reason being is that's what most ovarian cancer presents as. Over 70% of ovarian cancer cases are these serous epithelial ovarian cancers. And ovarian cancer is kind of an umbrella term. When we say ovarian cancer in the literature, or we're talking about some ovarian cancer diagnosis, we're often talking about serous epithelial ovarian cancer. We're also talking about fallopian tube cancers, which present like, behave like, and we treat like ovarian cancer. And we're also talking about primary peritoneal cancer, which again, presents like and behaves like ovarian cancer. And a lot of people don't know what the peritoneum is. And so the analogy I use with my patients is, if you think of your body as a garbage can, which is not the nicest thing to think about. Think of your body as a garbage can. Think of the intestines and all that as the garbage. Your peritoneum is the garbage bag. It's that inside lining of the uterus. And so one of the things I talk about with my patients who are going to have their ovaries removed to prevent an ovarian cancer if they carry a genetic mutation that puts them at increased risk, I say, this is 99% effective, but it's not 100%. And the reason being is there's a small but known risk of developing what's called primary peritoneal cancer. And again, it presents like, it behaves like, and we treat it like ovarian cancer, but it doesn't start in the ovary, it starts in the peritoneum. So these terms, again, fall in this umbrella idea of ovarian cancer. But ovarian cancer also encompasses a lot of other diseases: mucinous ovarian cancer, low-grade serous ovarian cancer, endometrial, clear cell, undifferentiated, borderline tumors or low malignant potential tumors, which aren't quite cancer, aren't quite negative, sarcomas, carcinoids, and sometimes ovarian cancer really is a metastasis from another organ, very commonly another GYN organ, and very commonly colon cancer. So all these things can be ovarian cancer. But again, usually when we talk about ovarian cancer, and for the rest of this talk, when I talk about ovarian cancer, I'm going to be talking about this umbrella term, this serous epithelial / fallopian tube / primary peritoneal cancer. So when you look at cancer in women, the most common cancer, as we know, is breast cancer. Ovarian cancer is actually not that common. Only 3% of all new cancer cases in women are accounted for by ovarian cancer. And we'll talk about exactly how many that is, but it's only about 22,000 cases a year, so it's not very common. Yet when you look at cancer deaths, ovarian cancer accounts for about 6% of cancer deaths. So although it's not very common, it is unfortunately potentially a lethal cancer. So these statistics are from 2010, and I apologize, I brought this from one of my talks, and it's updated, but not too much has changed. So the most common GYN cancer in the United States is uterine or endometrial cancer. And there are about 66,000 cases now in 2020. And the reason we keep seeing this number go up is one of the biggest drivers in uterine cancer is age, and we have an aging population, and that's a good thing. We want people to get older. But one of the other driving factors is obesity. And so we're getting older and we're getting fatter. And that extra weight that we all carry around our midsection, especially in women, converts a precursor hormone into estrogen. And that estrogen stimulates the uterus and stimulates the endometrial lining, and it causes those cells to replicate and eventually make a mistake that can lead to a pre-cancer and eventually a cancerous lesion. So that's why uterine cancer is the most common. You see, the next most common in the United States is ovarian cancer. All right, with, like I said, about 22,000 cases a year. And you see, cervical cancer is actually not that common, only 12,000 cases. And the reason for that is we have great screening programs in the United States, including pap smears. And we also have the HPV vaccine, which all boys and girls should be getting, preferably before they become sexually active. The current vaccine has 9 different HPVs it protects against, including genital warts. And really, in today's age, really no one in the United States should be diagnosed with cervical cancer. And in fact, 50% of women in the United States who are diagnosed with cervical cancer have never had a pap smear in their life. So either they come from outside the United States or they're in the U.S. and unfortunately don't have access to healthcare. So we should continue to see that cervical number shrink, and hopefully we'll start to see that endometrial number shrink. But here you see the number of deaths for these cancers. Now you see again the change. So although ovarian cancer accounts for only about 30% of GYN cancers, it accounts for more than 50% of the deaths, okay? And these statistics haven't changed too much, unfortunately, in the last 10 years. So this is a slide that I think is important. And what it shows here is a woman's lifetime's risk of developing a cancer. And what you see is 1 in 3 women will develop a cancer in their lifetime. And that's kind of a crazy statistic. And so it's very important that we talk to our sisters and our moms and our grandmothers about their cancer history. Because when you go to see your doctor and they ask you, has someone in your family had a diagnosis of cancer, the answer is probably going to be yes. But it's important to know what kind of cancer and at what age was abuelita diagnosed, because it makes a difference. So you see your risk of developing any cancer is 1 in 3, breast cancer 1 in 8, but your risk of developing ovarian cancer is fairly low, 1 in 70, okay? So your lifetime risk, if you don't have any family history or any genetic predisposition, is really 1.6%, so very low, okay? And that's a good thing. And as we talked about, ovarian cancer is the second most common gynecologic cancer, only about 22,000 cases a year, but about 15,000 deaths. It's the most lethal gynecologic cancer, in part because 70 to 85% of women who present with ovarian cancer present at an advanced stage where it becomes harder to cure. So what are some risk factors for ovarian cancer? Well, age is a risk factor as we get older. Family history, as we talked about. Infertility and low parity, and also personal cancer history. What are things that decrease your risk? Birth control pills. So I know that sometimes there's some misinformation about birth control pills, but actually if you're on birth control pills for more than 5 years, it decreases your risk of developing ovarian cancer by 50%. I know there's some concern about, John, does it increase my risk of breast cancer? And the data's kind of split on that. The one thing I tell my patients is, well, if it does increase your risk of breast cancer, we have a way to screen for breast cancer that works pretty well in mammograms. We have no way to screen for ovarian cancer. So I'm not sure if it increases or doesn't. Again, the data's mixed, but at least we have a way to screen for ovarian, breast cancer. We have no way to screen for ovarian cancer. And you see also decrease your risk of pregnancy, tubal ligation, and now we finally kind of understand that. We never really knew what that was, and we thought maybe you seal off the tubes and decrease inflammation to the ovaries, but what we figured out is, well, we're removing these fallopian tubes, and again, much of that ovarian cancer is actually in the fallopian tubes. So having this tubal ligation is benefit, and breastfeeding. So the three things that birth control pills, pregnancy, and breastfeeding have in common is it decreases your ovulation cycles. So one of the theories about ovarian cancer is every month your ovary ovulates. In other words, that epithelium ruptures, you release a follicle or an egg, and it has to repair itself. And it does this every month. When you're on birth control pills, you're not ovulating, so your ovary's not undergoing that trauma. When you're pregnant, again, you're not ovulating, so your ovary's not undergoing that trauma. And when you're breastfeeding, you're also not ovulating. So all these things prevent ovulation. Things is your family history. So, sorry, I got my dog into the room here. Family history is important. So again, if you have no family history, your lifetime risk of developing ovarian cancer is 1.5%. If you have a first-degree relative, that means your mom, your sister, okay? That's 5%. Now, this is difficult in the Hispanic culture because everyone is a tia, everyone is an abuela. So it's really important to really know who's truly a first-degree relative and who's a second-degree relative. Okay, we increase that risk about 7%. And if you have one of the known hereditary breast ovarian cancer syndromes, like a BRCA mutation or Lynch syndrome, that increases that risk to about 40%. So again, family history is so important here to knowing and understanding your risk for ovarian cancer. A lot of times patients say, well, John, I get my pap smear every year, so that protects me against ovarian cancer, right? It does not. So remember, a pap smear takes cells from the cervix, and the pap smear screens for and prevents cervical cancer. It does not screen for ovarian cancer, and it does not screen for endometrial cancer. So it's very important that you get your pap smear, but you also understand the limitations of pap smears, okay? So unfortunately, there is no strategy for the early detection of ovarian cancer. And that's what a screening test is, right? If you get your mammogram, that doesn't mean you're not going to get breast cancer. But it means that if we find this breast cancer, we're going to get it early when there's a better chance to treat and cure it. If you have a colonoscopy, that doesn't mean you're not going to get colon cancer, but you're going to catch it earlier. Unfortunately, we don't have any way to catch ovarian cancer early. So people will say, well, my GYN does an ultrasound every year, and I get that blood test, the CA-125. Well, unfortunately, those two things, both independently or together, have never been shown to do what we want it to do, which is to catch and detect ovarian cancer early. And there's some downside, what's called false positives. So you have an abnormal CA-125 test, and you undergo a surgery to make sure you don't have an ovarian cancer, which you most likely don't because we talked your risks are so low. But then you can have side effects from the surgery. Maybe you have a surgical complication. And so when they did these studies that looked at this, they saw that the risk from a surgical complication did not outweigh the potential benefits. Now, most of these studies were back when we used to do open surgeries. There's not a lot of good new studies looking at minimally invasive or laparoscopic surgery. But nonetheless, I think the numbers, you have to do about 150 surgeries to try and find one ovarian cancer, and that doesn't even mean it's going to be an early stage ovarian cancer. So right now, unfortunately, the blood tests, ultrasounds, even though some none of them have been shown to be of benefit. And remember with the blood tests, in women who are postmenopausal, a normal number for that CA-125 is 35. So if you have something above 35 and you're postmenopausal, that's considered abnormal. But if you're premenopausal, that number can go up to 200 before we consider it abnormal. And there are lots of things that can make your CA-125 be elevated in young women, like your menstruation, any kind of pelvic infection, ovulation, other cancers. So it's really not a good marker for young women. And I get lots of women referred to me, their primary care doctor or their OBGYN is trying to do something for the patient by screening with a CA-125 and it comes back 97. And the patient's so worried because she thinks she has ovarian cancer, and I have to really talk them down and let them know that, you know, this number is actually normal for someone your age. And plus, we don't really use it as a screening test. So I know doctors are trying to do good by ordering these things, but it really doesn't help. So what can you do? The most important thing you can do is know your personal and family cancer history, okay? And remember, family history changes. That uncle of yours that was fine last Christmas, you see him now in the holidays and he has a new diagnosis of colon cancer. Well, that's important because that might change your risk factors, okay? And so it's not nice to talk about these things. In Hispanic culture, we definitely don't talk about cancer, but it's so important to know, again, what did Abuelita have, which cancer did she have, and when was she diagnosed? And it's not just enough to know, oh, it's down there. We really need to know, was it a cervical cancer back in Cuba, where they don't really have good pap smear screening? That makes a big difference versus an ovarian cancer. So it's really important. The best thing you can do is know your personal history, know your family history, and know that it changes. So my patients see me in the office, first thing I say is, after we go through our pleasantries, anyone new in your family diagnosed with cancer? Because that changes, and that can change the impact on you. So women who do have an ovarian cancer are recommended to undergo genetic testing, all right, to see if we can identify a genetic mutation which might impact their personal screening, certainly their family members, and their treatment. All women diagnosed with breast cancer now are recommended to undergo genetic testing. This is new. In the past, it had to be a breast cancer, a certain type, by a certain age, on the family members. Now, the American College of Surgeons has recommended all women diagnosed with breast cancer undergo genetic testing. So if you have a history of breast cancer, you were never tested, you should. If you have a history of breast cancer and you were tested 5 years ago, you should get an updated panel testing because we've learned a lot in 5 years. There are a lot of new genes that we now know are associated with breast and ovarian cancer that we just didn't know about 5 years. And no, 23andMe is not enough. Those look for only Oncology found. They're Jewish mutations, which again does not account for many other cancer mutations. So you really need to see a genetic counselor, all right? All women who are Oncology Jewish descent should be undergoing genetic testing, okay? And again, if you have a family history of breast, ovarian, uterine, colon, pancreatic, brain cancer, these things may put you at increased risk. So get your cancer history and share that with your primary care doctor or your OBGYN when you go see them. So what else can you do? Well, with the help of your OBGYN, you can kind of maintain a good level of suspicion for any new signs and symptoms of ovarian cancer. When I was a medical student, I was taught that ovarian cancer was a silent killer. And you do enough of these talks to ovarian cancer survivors and support groups, and they will get very upset if you tell them it's a silent killer. They will tell you, I had symptoms. I told my doctor about them, but they didn't do anything. And that's not an uncommon thing. The challenge is that the symptoms are very vague and symptoms that many of us might experience. So these are the most common symptoms that women will experience: increased abdominal size, bloating, pelvic or abdominal pain, difficulty eating or feeling full quickly. And again, this is not uncommon. Probably many of us experience some of these symptoms today. But what you need to be aware of, how often are you having these symptoms? Are you having these more than 12 times a month? And are these new? This is something you weren't having a few months ago, and now you've noticed over the last couple months you've been experiencing these things. So if you have these symptoms and you're experiencing them, you need to bring them to the attention of your OBGYN or your primary care physician, okay? So again, know your personal history, bring these symptoms to the attention of your OB/GYN or your primary care doctor. And if you feel that you're not being heard, be your own advocate. Remember, there are only 22,000 cases of ovarian cancer a year. So it's not uncommon if you go to your primary care doctor and tell them, listen, I've been having bloating for the last couple months. They're going to say, and rightfully so, well, this is probably GI related. Let me have you go see the gastroenterologist. But you know your own body. If you have a couple of these combination of symptoms, be your own advocate. Ask for, at that point it would be appropriate for a CA-125 and a GYN ultrasound, okay? You want to try and do things in parallel. All too often when I see a new ovarian cancer patient in my office, they've already seen the gastro, they've already seen the urologist. By the time they've gotten to me, they've been working through this diagnosis for 3 or 4 months. And the reason is these symptoms are so subtle, and most likely, in most women, these symptoms are attributed to something else. But if you're having these symptoms, they're occurring multiple days of the month, it's something new, be your own advocate. Push for, in addition to seeing your gastro, for that CA-125 and that GYN ultrasound. So what else can you do? Lifestyle modifications. I know it sounds funny, but diet and exercise. Time and time again, studies have shown not just for ovarian cancer, but for all cancers, diet and exercise can reduce your risk of developing ovarian cancer and other cancers. Avoid environmental toxins. So obviously smoking with lung cancer, right? But there's an interesting study. You look at Japanese women, and you looked at the type of cancers that are common in Japanese women who live in Japan. You take those same group of women who have now moved to California, and for the first generation, they continue to get those cancers that are similar to their Japanese counterparts that still live in Japan. But a generation or two later, when you look at the cancers they get the same type of cancers that women in the United States get. So definitely genetics plays a role, but environmental plays a role. So I'm not here to tell you exactly how to eat, but I think there's something to try and avoid processed foods when appropriate, organic, eliminate hormones and antibiotics in your foods. So avoid environmental toxins. Sleep, get enough sleep. Manage your stress. There's a great study that Emil Sood did at MD Anderson where they took rats and they found that rats, they were giving beta blockers, which is normally a medication we use for control your heart rate or blood pressure, but it also makes you decrease things, kind of a less stressful state. And in those rats who were given beta blockers and also were given ovarian cancer cell lines, they developed less ovarian cancer tumors than those rats who were not given the beta blockers. So managing stress is important, okay? And accept help. People are sometimes very unwilling to accept practical and emotional support, and that's one of the great things that Tracy and this group does. I think it gives access to people to have that practical and emotional support, to get education, to vent, to see that you're not alone in this. And all these things really do reduce your risk of developing ovarian cancer, okay? And so this is what we're dealing with. This is ovarian cancer. You can see here's this little uterus here, and here's this big ovarian mass. Now, it's not always so dramatic, okay? But if you get diagnosed with ovarian cancer, it's very important to know the next steps in management. And so we know that women who have the appropriate surgery, what's called a cytoreductive procedure, which means you remove not just the ovary and the uterus, but any visible tumor, have the best overall survival. Now, not every woman is a candidate for this, and not every surgeon does the same surgery. So it's really important, if you're diagnosed with ovarian cancer, to be sure you're being treated at a center that has a high volume of ovarian cancer and people who are really dedicated to this. So there's always a combination of surgery and chemotherapy in the management of ovarian cancer, and the question is, which one do you do first? And that will be based in large part to how you present and also to the surgical skills of the team that's taking care of you, okay? The chemotherapy you likely receive is called carboplatin and paclitaxel. Sometimes you'll be given another medication called bevacizumab, which is not a traditional chemotherapy. It's a monoclonal antibody that inhibits cell proliferation through the VEGF pathway. And now you should be offered maintenance therapy. And again, this all changed, the maintenance therapy, in the last year for ovarian cancer. It's been a really exciting year in the management of ovarian cancer with the use of PARP inhibitors in the upfront setting. So sometimes we'll get chemotherapy first if we're not a good surgical candidate. And what this does is it starts to eliminate the disease and can make what was going to be a very radical surgery into a less radical surgery. And this can perhaps be done robotically. And so We're one of the few centers that performs robotic surgery for the management of ovarian cancer. And this is a little video I'll play just while we talk about it. So this is the robotic platform. You can see here in my left hand is one of the robotic instruments. There is one of the, and there's not any blood here in case anybody squeamish. There in my right hand is the scissors that we use this robotically, okay? The benefits of robotic surgery is you can do these surgeries through small little 8mm incisions. Thereby it's a much quicker recovery for the patient. Also means you can start chemotherapy sooner. And we know there's some studies that have shown if you can get to start your chemotherapy sooner, that you may do better. Now, again, not every woman is a candidate for a minimally invasive approach, and you really need to be treated at a skilled center. But you can see there in my left hand is the tumor mass. You can see it there. And this is a woman actually who had a recurrence of ovarian cancer, and we're getting the mass off the colon there. And so again, this really should be done by expert centers that have experience with robotic surgery and the surgical management of ovarian cancer. So once you finish your surgery and your chemotherapy, nowadays you should be offered a PARP inhibitor. And PARP inhibitors are a new class of drugs. They're oral medications, so unlike the chemotherapy received during your treatment, which was given IV, this is a pill you'll take one or twice a day, depending on which PARP inhibitor you're recommended. And the FDA a few months ago approved PARP inhibitors for all women. So before it was approved only for those women who carry a BRCA mutation, either in their blood, so themselves, or their tumor had it. Now, a PARP inhibitor is approved for women who both carry a mutation and do not, and they've all been shown to be benefits. So really all women now should be offered PARP inhibitors and maintenance therapy, and we know this has improved outcomes dramatically. One of the things that I also do is I lead the clinical research efforts, and I always use PARP inhibitors now when I talk to my patients about clinical trials. So I was a fellow at Sloan Kettering when we did the first phase 1 trial for PARP inhibitors. That was 14 years ago. So it's taken 14 years from when we did the first phase 1 trial to bring this to market in the upfront setting. So when I offer a clinical trial to patients, especially a phase 1 trial, I tell them, you know, one of the benefits is you have access to a drug that we're probably not going to see for another 10 years in the market. Of course, one of the downsides of phase 1 trials, we're not sure if that drug's going to work. So these are one of the things that I'm passionate about, and this is clinical trial funding. And you can see that prostate cancer is the most funded cancer, despite the fact that prostate cancer is probably one of the least deadly of the cancers listed up here. But it affects men, and I'm sure that's why it gets the funding it gets. Breast cancer is the next highly funded, and this is in large part, obviously it's a very common cancer among women, but I think the advocacy groups have done a great job about bringing notice. I mean, the NFL in October has Breast Cancer Awareness Month. All the players wear pink. So I think this is great. We look at GYN cancers, ovarian cancer. The funding is really low. Cervical cancer, uterine. And this needs to change. This is the only way we're going to bring about change and improvement in the outcomes in women. And it's by us raising awareness, by us demanding increased funding for these cancers. So this is a great site. It's the Foundation for Women's Cancer, and this is a site for women. It's for patients and caregivers and advocates, and there's a lot of great information there. We do a run every November. There's a lot of great information there. You see September is GCAM month because now it's the Gynecologic Cancer Awareness Month. And it's a great resource, and I encourage my patients to go there. Both there's information about the disease, it helps you find a good Gyno-oncologist, and it's just a great place to meet. And this is the website for it. You have to go to it now. So I want to leave with these thoughts. Ovarian cancer represents a really heterogeneous group of cancers. So when we say ovarian cancer, we have to be kind of specific what we're talking about. But usually when we say ovarian cancer, we're talking about that serous ovarian cancer, that umbrella term, fallopian tube and peritoneal cancer. Your chance of developing ovarian cancer is low, but know your risk, know your family history. That's the biggest predictor. Genetic evaluation is essential, okay? If you have a family history or a personal history of cancer, you should get genetic evaluation. It can change the trajectory for yourself, and it can change the trajectory for your family. Unfortunately, right now, there's no screening for early detection of ovarian cancer. Again, I understand that some primary care doctors and some gynecologists offer yearly ultrasounds or yearly CA-125s, but again, these things have not been shown to be effective. we talked about before, communicate with your OBGYN or your primary care physician about any new symptoms that you're feeling, okay? And don't let yourself be blown off. And it can sometimes be difficult if a doctor tells you, oh, listen, don't worry about it. You know your body, you know what's not right. If you're having these symptoms more than 12 times in a month, if you're having these symptoms have changed over the last couple months, be your own advocate, okay? And don't do things in a stepwise manner. Don't go see the GI first and you'll see the urologist. Ask them. It's non-invasive to have a blood test and an ultrasound. I understand transvaginal may be a little bit uncomfortable, but really it's not that invasive procedure. And potentially you could find these things months earlier while you begin your workup for these symptoms. So know the symptoms and be your own advocate, okay? If you're diagnosed with ovarian cancer, please seek someone who specializes in the treatment of this disease. Not all gyno-oncologists are treated equally. We all have different interests. We all have different expertise. Be sure to find someone who specializes in the management of ovarian cancer. And the evolving therapies. HIPEC, we just presented our randomized controlled trial at ASCO this summer on HIPEC for the management of ovarian cancer. There was an England Journal of Medicine article on HIPEC from the Netherlands. So this is something we're incorporating into the treatment of ovarian cancer. PARP inhibitors has revolutionized the way we manage ovarian cancer. And that's cannot be stated enough. It's really been a game changer, and I'm grateful for these class of drugs. And we're hopefully moving to personalized medicine, where it won't be an umbrella term for ovarian cancer. It will be you carry a BRAF mutation, you carry a KRAF mutation, you have a 53 mutation, and we're going to be able to target specific treatments for these mutations, and no longer are they going to be based on where they started, be it breast cancer, ovarian cancer, colon. It's going to be based on genetic mutations. We're not there yet. We're learning a lot about this daily, but that's where we're moving to. So I thank you very much for your time, for paying attention. I hope this was educational for you guys. I'm always on Tracy's Instagram, so you can find me there. But if not, you can reach me here on any of these social medias. And thank you again, Tracy, for the opportunity. And I'm happy to take any questions. And I think I went longer than I planned to, so I do apologize. But thanks.
Thank you so much for coming on. I appreciate your time and dedication to always coming on to educate our community. As you know, this month for me is important. I've always found Ovarian Cancer Awareness Month, now Gynecological, Awareness Month, so important because so many women don't know what to do or don't follow through with the doctor. So I appreciate your time. And what I would like to do is, if you guys have questions, you guys can raise your hands and we can slowly go into questions one at a time. So let's first start with somebody. Melissa, go ahead. So Melissa, I'm gonna unmute you. Maybe you just want to do like a short intro, just so everybody knows who you are as you're talking, if you don't mind. Awesome.
And so, hi, Dr. Diaz. My name is Melissa. I'm going to jump into the heavy stuff right away. So I'm here on behalf of myself and my sister. We're both BRCA1 positive. We've both had hysterectomies. I had a supracervical. She had a total hysterectomy. We both had ovaries and tubes out. Hers was 2 years ago. Mine was just this past February. So last week she was diagnosed with primary peritoneal cancer. So the fear that we all have, it has arrived. So right now, she's ridiculously overwhelmed. So I'm doing a lot of the legwork on her behalf and doing a lot of the research. We're in New York, which is good. We have lots of options here. The problem that we're experiencing is there are multiple options for her treatment. So luckily she's stage, I think it's 3B. It's minimally present. It's just in her omentum as we understand it. There's some ascites. She's lucky. The problem is we were at Sloan Kettering today. And
who did you see at Sloan Kettering?
We saw Dr. Tiffany Troso-Sandoval.
Okay.
We were not offered an appointment with any of the HIPEC surgeons, notwithstanding that it was requested. And
so she's not had her surgery yet. Sorry.
No, she has no treatment. So she was just diagnosed. Via, like you said, she wound up going to the gastroenterologist. She had, urinary tract symptoms. Ultimately, she had a CAT scan that showed some nodularity. Then her GI wanted a PET scan, insurance denied it. So she had an MRI that was clean. And then the gastro luckily pushed her to have a biopsy of the omentum, and that's how they found it as high-grade serous adenocarcinoma. So Sloan says, you know, no matter what, you need to have surgery first, followed by the 6 rounds of chemo. It's always best to have surgery first. Meanwhile, we had an appointment at Mount Sinai with their HIPEC specialist, and he recommends 3 rounds of chemo to make sure that she's responsive to the chemo, followed by cytoreductive surgery with the HIPEC, followed by 3 more rounds of chemo. And Sloan is like, no, 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 you have to do surgery first because that's going to prolong your life the most. And so, you know, it's hard with the new therapies, and obviously, you know, followed by PARP inhibitors and the chemos. You know, there's no magic to the chemo; it's the same stuff no matter where you go. So, you know, I'd like you to talk to me a little bit about like the HIPEC trial that you did, because, you know, my mom's like, oh my God, you know, they're going to burn her alive. And my sister's like, I don't want something experimental. And I'm like, okay, you could give me 3 options where I have chemo, surgery, plus the abdominal chemo. I'm in. Give me everything you got. You know?
Right. So full disclosure, I train at Sloan Kettering, so I'm a little bit biased to Sloan Kettering. And if you want to, you can get my information from Tracy later. Send me a text, and I will send you send the text to my 2 friends and mentors, and I'm sure they will get you in or get her in immediately. So I'm biased to Sloan Kettering. The clinical trial that we did was actually one of the HIPEC surgeons at Sloan Kettering. Ollie and I were fellows together there, and our mentor is Dennis Chi, who really literally writes the book on ovarian cancer surgery. So I think you're in great hands at Sloan Kettering. Again, I'm biased, that's where I trained. So the study that we did, Ollie and I, and Dennis was our senior author on it, was looking at HIPEC in the recurrent setting. The reason we chose the recurrent setting was there really was no data or not much in the upfront setting, and it was just difficult to get it through the IRB from a concept standpoint. So we were just so we found that it was effective in the recurrent setting. After our trial was started, the Netherlands presented a trial in the upfront setting. The caveat to the Netherlands trial was that, as it's been recommended at Mount Sinai, which is that, yes, you would get 3 cycles first and then get the HIPEC. Now, those patients who went on to the Netherlands trial to get the chemotherapy first were patients who they felt that they could not get an optimal cytoreduction in the upfront setting. So if for any reason you're unable to get an optimal cytoreduction with the surgeons at Sloan Kettering, and I won't speak for them, but I would assume that if they then take you back to chemo afterwards, then you would get the HIPEC at that time. But again, my bias, I trained there, and go ahead.
They're not, basically what the surgeon at Sloan Kettering said today was, I would not recommend doing HIPEC for you because it's chemo first. The only thing I would recommend for you is cytoreductive surgery followed by 6 rounds of chemo.
Right, and so the idea there is, if you have a cytoreduction and you have an optimal cytoreduction, which is the best surgical outcome, then you're right, we don't have a role for HIPEC in that setting. When those patients do the best. If you can have an optimal upfront surgery and then receive your 6 cycles of chemo, those patients seem to do better than those who get chemo first with HIPEC and then more chemo. So the thought is, the sooner that you can have an optimal surgery, and again, not everyone's able to, but the sooner that that can happen, the better your outcome is. And so that can be done in the upfront and then get 6 cycles of chemo. Those are patients that we know have the best outcome.
And because there's no comparison now to, there's no comparison now to show that, for example, upfront surgery with the HIPEC is better than. So
that's the next trial that Ollie and I are writing up, but we don't have that trial yet. So we think so, but that's what Ollie and I are literally working on. So.
With Sloan, okay. So he's at Sloan.
Yeah, so Sloan Kettering did a very admirable thing, and they created an ovarian cancer team. And that's why I said not all gyno-oncologists are created equal. And so they took those gyno-oncologists who specifically had an interest and skills in the surgical management of ovarian cancer, and they created what's called Team Ovary. So the lead of that is Dr. Dennis Chi. And on Team Ovary is Yukio Sonoda, Oliver Zivanovic, who's my co-fellow, Carol Long, who is also my co-fellow, Ginger Gardner, and Elizabeth Jewell, I think, is also on that team. And those are the 5 surgeons who specialize in ovarian cancer surgery. Again, if you want Melissa to get my information from Tracy and text me after this offline, I'll get your sister information to Ollie and Dennis, and I'm sure they'll reach out if you don't have an appointment yet with one of the surgeons.
We met with one of the surgeons there in Uniondale today, on Long Island. Dr. Tiffany Troso Sandoval.
Is Tiffany a medical oncologist or a surgical oncologist?
Oh, I'm sorry. You're right. That was the medical oncologist. The surgical oncologist we met with was Jennifer Mueller.
Okay, Jen. Yep. Jen is excellent as well.
Okay. So you don't think I need to get on Team Ovary? You think Jennifer's okay?
No, so if Jen saw you, Jen is now on Team Ovary. So Jen is one of the younger attendings, but she's excellent. And the great thing about Sloan Kettering, and we do this now at MCI, they work as a team. So it won't be just Jennifer who will be presenting surgery. She will have a full complement of all the senior surgeons there as well. And you're in excellent hands with Jen. I've known her for a long time. Okay.
All right. So I guess what it comes down to is, if Mount Sinai for her, and this is what I would do for me, is I would say to the doctor at Mount Sinai, if you're willing to do the HIPEC up front, it sounds like a winner for me, even though it's not clinically, proven yet. The problem is that I guess the risk is, what if in HIPEC, like, I guess this is one of the things you're considering, is what if the particular patient is not responsive to the chemo that you're choosing to then put in the abdomen? It's kind of like a waste.
So that's a risk. The risk of that is about 10 to 15%. So it's not negligible. And that's, potentially part of why we're not using the upfront setting. I know we have a couple of people have questions. So the one thing I would tell you, Melissa, and again, I'm biased, Sloan Kettering literally writes the book on ovarian cancer surgery.
Okay, thank you.
And they're great surgeons at Sinai. I know them well, and I share several patients with them down here up there. But if you're in the New York area, Sloan Kettering is where I would go for ovarian cancer surgery. No
okay,
question.
Thank you so much. I appreciate your time. I really do.
Kamali.
Of course, my pleasure. Best of luck.
Thank you.
Kamali.
Thank you. Hi, Dr. Diaz. I'll keep it short, but I do have a few questions.
Yes, go ahead.
So I am BRCA2 positive, stage 3C ovarian cancer. I am in New York as well. No family history. I'm from the Dominican Republic. No, everyone there is A-okay. Everyone here is fine. Anyway, so I'll make it as short as possible. So first, what would you say are the recurrence rates for BRCA positive? So again, 3C, I had IP, intraperitoneal chemotherapy. I had IV as well. What are the recurrence rates for someone like me?
Yeah. So are you on a PARP inhibitor now?
I'm on Lynparza since May.
Okay, great. So I think with Lynparza, you greatly reduce your risk of recurrence. And we've seen that with the use of Lynparza, which is one of the PARP inhibitors, and actually the first one that we used and the one that we have the most experience with, we know that what we call progression-free survival, so from the time that you are starting the medication to if and when the cancer comes back, has been greatly increased on Lynparza. Can it come back? It can, okay? And I'm sure your physicians are keeping a close eye on you with CA-125 and periodic CT scans. But I think that if you had IP chemotherapy, again, I'm biased to that as well, but I think that's one of the most effective chemo treatments that we have. And the fact that you're BRCA2 positive and on olaparib, I think you've given yourself the best chance to try and beat this cancer, and certainly give yourself the longest interval from having this cancer come back. Having said that, we do know that ovarian cancer is one of those cancers that do come back. in some women. And if it does, and you've had a good response to the upfront setting, you will likely have a good response if and when it comes back. So I think that there's a risk. Obviously, we know that with ovarian cancer, but the fact that you carry a BRCA2 mutation and are on a PARP inhibitor now after receiving appropriate chemotherapy, and you're likely in remission at this point, is great news.
There aren't any numbers for, I mean, I know they have the recurrence rates as high as 80% for someone who's not BRCA positive, but there isn't a number for BRCA. I'm not scared of the numbers. Go ahead, tell me.
So we don't know in the new world of PARP inhibitors. We know that despite our best efforts, women with advanced ovarian cancer, about 70% of women are going to have that cancer come back. With PARP inhibitors, we don't yet have the data to see if it decreases that recurrence, but we know that when it happens, it certainly happens much longer out than it does without a PARP inhibitor.
About 4 months or so, right? Or is that a little bit longer?
No, PARP inhibitor is much longer. So without a PARP inhibitor, we usually see the recurrence at about 12 to 14 months. Again, everybody's a little bit different. With PARP inhibitors and a BRCA mutation, we see that women who are on the SOLO-1 trial, which would be your type of women that carry BRCA mutation on a PARP inhibitors, at 3 years of follow-up, half women had not yet recurred.
3 years. Oh, that's promising.
So that's great.
How often do you see, or how often or common is it that someone can change oncologists? Like someone like me who's not recurred, I'm healthy, no evidence of disease. Do you change oncologists? I mean, I'm happy with mine, but just curious.
Yeah. So I see a lot of second, third, and fourth opinions, in part because of my interest in clinical trials and clinical research. I have a patient who I operate on today. I met her a week ago, and her daughter understandably was nervous about her new suspected diagnosis. To make matters worse, it's COVID, so family members can't really come to visits with physicians, and she lives all the way in Arizona. And so she asked me, what about a second opinion? I said, absolutely, get a second opinion. And who are we going to see? And again, there are not that many of us. We all kind of know each other. She mentioned she wanted her mom to see. I said, absolutely, I'll send him a text today. I'll let him know what's going on, and here's a copy of my note. Take it with you when you go see this person. So I think second opinions are great. I think, though, right now, if you're in remission and you're on olaparib and you like your oncologist, I don't know that right now there's a reason to get a second opinion, because I don't think there's going to be something different. If things should change in the future and this cancer comes back, and at that point you get one opinion from an oncologist, I think it's perfectly reasonable to get another opinion and see what someone else thinks. So he might recommend, or she might recommend, either chemo or maybe surgery, and someone else might have a different opinion, or they might be a clinical trial. So I think second opinions are great, and I encourage all my patients to get a second opinion. I tell them from the start, I don't take it personal. I would get a second opinion too.
Tracy, you sure I can continue, or I can ask another?
If you have another question or two, go ahead. There's a couple questions after you, but.
Okay. How often do you recommend, or would you put a patient on, someone like me who's on Lynparza, but I've got this BRCA mutation, and so I've got this breast surgeon saying, for the time being, maybe you should consider being on Lynparza and tamoxifen. To me, I just think my quality of life will be decreased even further, so I can't even visualize that, but.
Yeah, so we don't have any great data on combination of hormone therapy like tamoxifen and PARP inhibitors. And as we know, olaparib specifically got approval for breast cancer. So I think you're likely covered from the breast cancer domain. I'm not a breast oncologist. We're just going on FDA approval for olaparib for breast cancer. And again, we don't have a lot of data on using tamoxifen in combination with it. Having said that, we do use tamoxifen, or I do, I should say, in the treatment of some of my ovarian cancer patients. And tamoxifen in general is pretty well tolerated, especially if you're already in cervical menopause from the ovarian cancer. So it's not unreasonable, but we're kind of in a data-free zone there.
Okay, and my last question, my daughter is actually going to find out tomorrow if I pass this on to her. If she is indeed BRCA positive, which I'm going to pray, tonight. Should she be seeing a gynecologic oncologist, or would she be okay with just a regular GYN?
Yeah. How old is your daughter? I'm sorry.
She's 27.
Did she go through Lenox Hill?
Yeah.
I'm sorry?
Did she go through like a center?
Does she work at a center?
No, did she go through a center for her testing?
Through Lenox Hill.
Okay, perfect. Okay, go ahead. Sorry, Dr. Diaz.
Yeah. So I think Elizabeth Pointer is at Lenox Hill right now.
I'm sorry.
And there are a couple of, I think Elizabeth Pointer is one of the G1 oncologists at Lenox Hill right now.
She is. She did my surgery.
Yeah. Okay. Yeah. It was just funny. She would wear high heels and pearl earrings into the operating room when I was a resident. So yeah, I think very reasonable for her to at least see and meet a G1 oncologist who can help coordinate her care with her regular GYN. So yeah, I think it would be important. Again, I'm biased. I'm a G1 oncologist, but I think most GYNs would want to be co-managed with a G1 oncologist.
Got it. Thank you so much.
Yeah, my pleasure. Best of luck.
Toby? Oh, hold on, you're muted. Wait. Go ahead.
Hi, Dr. Diaz. How are you? Always great to
Good. How are you?
hear you and learn something new no matter when you come on. So here's my question. Although I do not carry the BRCA mutations because I've never gone through genetic testing, during your slide presentation, you mentioned monoclonal protein. Am I correct?
For the PARP inhibitors?
Yes.
Yeah.
No,
So one of the...
I'm listening.
Yeah. So the way we think PARP inhibitors work is, the BRCA, as you guys know, the gene works in repairing cells. And those women who are have a deficiency or carry that mutation have an inability for those cells to kind of repair itself, which is actually why women who carry a BRCA mutation actually do better with chemotherapy, specifically with platinum-based therapy. And so PARP inhibitors are kind of work along the same way. So that PARP protein helps to repair cells. So if you carry that BRCA mutation, you have already one kind of way for the cell not to fix itself, and then use a PARP inhibitor and you block another way for those cells not to fix itself. That's why we see the best benefit of PARP inhibitors in those women who have already that repair defect. Because now there are two ways that the cell cannot repair itself. And so if a cancer cell can't repair itself, then that cancer cell dies, and that's what we want, obviously.
Okay, so if you carry that monoclonal protein and you're being treated with chemotherapy at this point, does that, and you know how I feel about genetic testing for myself, does that mean that I should immediately go for the BRCA testing because I'm already going through, all this medication with chemo for carrying that monoclonal protein?
Yeah, so absolutely. Anyone diagnosed with a new ovarian cancer should undergo genetic testing. Again, the FDA now has approved PARP inhibitors for all women, regardless of their genetic, whether they're carriers for a BRCA1 or 2 mutation, but it's important because you can also manage expectations. So we know that women who are treated with PARP inhibitors and carry a BRCA1 or 2 mutations are the ones that seem to do the best on PARPs. That's not to say that there's not benefit in women who don't carry a mutation, but you can better counsel your patients as far as what we can kind of expect and whether it's reasonable to pursue it. So, PARPs are great and most of them do great, but anything has side effects. And so if you're really struggling with this medication, or if it's really impacting your blood counts or needing transfusions, and you don't carry a BRCA mutation, then we have to kind of weigh, all right, well, so how much are we truly gaining with this PARP inhibitor compared to how much of an impact it's having on your quality of life? Remember, this is not chemotherapy where we say, well, suck it up, it's only 6 cycles, we'll get through it. The idea is you're going to be on this for years. And so it has to be quality of life. So if you're really struggling with the side effects of this maintenance therapy, and you are a non-carrier, maybe the side effects don't outweigh the benefits. So it would be important to know.
Well, actually, I've
Having
truly
said
been
that, all these
blessed.
parts,
I had
yeah, all
started
these
out
parts
and my
have multiple
numbers were
dose
at
levels.
16 and my numbers are down to 5. In 15 months, I actually am on, they call it maintenance, because with, you know, with that carrying that one that one monochromal protein, you know, there is no what shall I say? There is no cure for it, but it's okay because the medications, thank God, have not bothered me, and I'm on them for 16 months.
So I guess the question is would it benefit her at this point, right? Because we're not talking ovarian cancer, we're talking multiple myeloma. To get BRCA tested, to qualify for a PARP inhibitor and benefit after what you just said with the whatever proteins.
Yeah, so we also got to work with FDA approvals for these things too.
Right. That was
so,
I don't think
yeah, so we don't have that approval. But again, olaparib has gained approval for breast cancer, pancreatic cancer, who carry the BRCA mutation. So I have a clinical trial looking at PARP inhibitors in cervical cancer, who obviously is not associated with BRCA mutation. So we're finding more and more treatments for this protein, or this blockade for this protein, as you said. So we don't have an FDA approval for that yet, but maybe down the pipeline.
Just out of curiosity, as that protein, does it go with BRCA? You know, like, so I think.
Yeah, so they work together. They work synergistically. So that's why we see BRCA patients do so well with PARPs, because they already have something that's inhibiting that DNA repair.
Okay, good. Okay, thank you.
It was also, I believe, Dr. Diaz, the same thing with the dexamethasone, that steroid that they said would be good actually for COVID, that they put cancer patients on. Am I correct?
Yeah. Yeah, and we have a couple trials that are looking at COVID. Thankfully, COVID's gotten a lot better in South Florida. Actually having a difficult time putting patients on trial because we don't have a lot of patients, which is a good problem to have.
Perfect. Let's see, Catherine, you had some questions?
Hi, this might sound like a totally ridiculous question, but I'm going to ask it anyway. I have a preventative fallopian tube removal surgery on October 21st up in Boston. And I live in Key West, and of course, I'm sure you know, being in South Florida, there's not a whole extensive amount of specialty people down here to see patients like myself. In the event I did have some sort of ovarian cancer, would they catch it while they're removing my fallopian tubes, or is there a chance that it would be missed?
Yeah. So, Catherine, I'm sorry, remind me. So you carry a BRCA mutation?
Yes, correct. BRCA2.
Okay. Yeah. So, and where are you going in Boston? To MGH or Brigham?
Dana-Farber at Brigham. Yeah, I see a preventive oncologist up there.
Yeah. So obviously Brigham is a premier institution, so their pathologist will know to cut the tubes, especially looking for any abnormality. I'm sure your oncologist talked to you that there is about a 2 to 3% chance of removing these fallopian tubes that they find something. So when we send our prophylactic fallopian tubes or ovarian cancers to the pathologist and they carry a BRCA mutation, or if I say, you know, carries a high suspicion based on family history, they will section it or look at it differently than, let's say, a woman who had her fallopian tubes removed and doesn't have that history. So they will look at it differently. The chance of you finding or them finding a cancer hiding that fallopian tube is very low, about 2 to 3%, but it's not zero. So they will look at it differently than they would for someone who doesn't have your history.
Okay, so if I happen to have cancer in my ovaries, but the whole point is I'm trying to wait as long as possible for my ovaries.
Sure, I understand. So if you have cancer in your ovaries, you know, they'll look at the ovaries, and if they see anything suspicious, also they'll take a biopsy or remove it. But is it possible that you could have a cancer hiding inside your ovary and that we might miss at this procedure? It's possible.
Okay.
Jen?
Yeah. So I'm preparing to do either an oophorectomy or a hysterectomy later this year. And I was just wondering if you had a perspective on who should do the surgery. I do have an oncologist. I feel like my gynecologist has really been pushing for another gynecologist to do the surgery, not my oncologist. And I've done, of course, a lot of research to know that a lot of people with BRCA and BRCA1 positive usually have an oncologist do this if it's preventative. And I'm just worried that like some guidelines would not be followed or something would be missed. And so I'm just wondering if you could offer a perspective on going with the gynecologist to do it versus just a general gynecologist.
Sure. And Jen, I'm sorry, remind me, do you carry a mutation?
Yeah, I'm BRCA1 positive, and I have already had a
BRCA1,
prophylactic
okay.
mastectomy.
Okay. So before I answer your question, I just want to take up a minute to talk about BRCA1 and the uterus, right? So we know that BRCA mutations 1 and 2 have an increased risk of fallopian tube and ovarian cancer, and so the recommendations are to remove the fallopian tubes and the ovaries. There's no association with BRCA2 and uterine or endometrial cancer. And with BRCA1, we used to think there was no association, but a couple of years ago, Noah Coffey used to be with me at Sloan Kettering, now at Duke, and now I think he moved again, but published a paper in JAMA showing that women with BRCA1 mutations don't necessarily have a risk of uterine endometrial cancer, but if they develop a uterine or an endometrial cancer, they have an increased risk of that being a serous cancer, which can be a more aggressive type. So in women who carry a BRCA1 mutation, we have to kind of counsel our patients differently than we did a few years ago. And it may not be unreasonable to undergo a risk-reducing hysterectomy at the time of removing the fallopian tubes and the ovaries. Now, as far as your question specifically of whether you should have a GYN or a G1 oncologist, again, I'm biased because I'm a G1 oncologist. But I would say absolutely the surgery should be performed by a G1 oncologist. And the reason being is we operate. This is what we do. Gynecologists usually do office gynecology, they deliver babies, and they do some surgery, but not really a lot. And so it's important when you have your risk-reducing surgery that the blood supply to the ovary, which is called the infundibulous pelvic ligament, is really skeletonized, and that they take their bites appropriately away from the ovary to give yourself enough margin, okay? But to do that, you get close to other structures, namely the ureters, and in general, gynecologists don't feel comfortable working in that area, so they will probably take it very close to the ovary. So I would recommend, if you're gonna have a risk-reducing surgery done to prevent a cancer, that you have that surgery done by someone who specializes in cancer.
Thank you. That's super helpful and gives me some validation of what I was already leaning towards. So thank you.
Yeah. Where do you live, Jen?
Raleigh, North Carolina.
Okay. Oh, you have great G1 oncologists in that area.
Yeah.
So
very
either
fortunate.
UNC or Duke. Yeah.
I go to UNC. Yep.
Oh, perfect. Absolutely. Yeah. Sean Bogus or some
That's
of the
who.
there.
Yeah. He's my oncologist.
Okay. John. Again, really wrote the book in Robotic, so I would absolutely have John Bogus do your surgery.
Okay, good. Woo, this is wonderful. Thank you. I can sleep better tonight.
Yeah.
Well, does anybody else have any questions before we let Dr. Diaz go? We really appreciate your time and again, your dedication to coming on and helping all these women and giving them information and some reassurance and some doctors for those of them that aren't local. Nobody from Australia tonight, Dr. Diaz. Does anybody else have any questions? Perfect. Well, thank you again. Thank you everybody for coming on and supporting Dr. Strong, where we continue to make sure we educate. And if there's anything you ever need, you can feel free to reach out to me, as I'm always here to help you and guide you through your journeys.